Hi there, this is Jennifer Smith checking in again. We're here today for home CCO enrollment for Oregon State Hospital discharge to adult mental health residential settings. We're going to talk today about coordinated care organization, CCO responsibilities, challenges, and solutions. And presenting with me today, I have Chris Norman, Michael Oyster, and myself. I'm Jennifer Smith. So we'll go ahead and get started. Our agenda for today, first of all, I want to let you know that the presentation was emailed to all registrants about 45, 50 minutes ago, so you should have received that. If you did not receive the presentation, go ahead and type your email address into the questions panel, and I will make sure that you get that immediately following the presentation today. Also, just so you know, the first several slides are background information. We will probably move through those fairly quickly. We're not going to cover them in detail, but they are included for your review. Today's objectives, we're going to understand the home CCO enrollment rule, its implications in the population it serves. We'll talk about CCO responsibilities for home CCO enrollment. We'll talk about operational challenges and opportunities for possible solutions. And we'll have some practice scenarios, and we'll outline next steps for CCOs according to the rule. I'm going to go ahead and transition to Chris Norman. He'll take over from here.
All right, thank you, Jennifer. This is Chris Norman. I'm the Delivery Systems Support Unit Manager for the Health Systems Division of OHA. So the slide that you see right before you, hopefully this is very familiar to everybody that's worked with CCOs since we've launched in 2012. This, of course, is all about the collaboration and integration of care, also between OHA, PCOs, providers, stakeholders, et cetera. Again, the triple aim, right service, the right time, at the right setting for the appropriate length of time. A big piece of that on the next slide is transitioning mental health residential treatment into coordinated care, and we are in the process of that right now. One of the pieces that we are working through with this stage is one part of that, which is around the enrollment and people transitioning from the Oregon State Hospital, but an important step for coordinated care in general is the full integration, which we expect in July of next year. And with that, to talk a little bit more about the importance of residential care, I'll turn over to Michael Oyster.
Okay, thank you, Chris. This is Michael Oyster. I'm the AIM High Coordinator for Health Services Division. And you know, really residential treatment's about transitioning the patient from the Oregon State Hospital into the community and toward more and more independence. That's really it's a path toward independence, back toward the home community. Mental health residential treatment is not always available close to home. Often placements have to be made around the state, and because of that, CCOs need to be in close coordination to be sure that issues are not having to be reassessed all over again, that we can build upon the past history of services.
All right, so again, this is not new information. The home CCO enrollment rule actually went live in September of this year, and we've had several webinars, a number of different presentations at different CCO work groups and other places. So this is really just a recap of what that rule is. And again, 410-141-3066 is the revised rule language around home CCO available on the OSH policy page. It's currently not on the Secretary of State website, but will be shortly. But the most important thing on the next slide is what home CCO means. And in 410-141-3066, Section 1B, home CCO means the enrollment in a coordinated care organization in a given service area based upon a client's most recent permanent residency determined at the time of original eligibility determination or most current point of CCO enrollment prior to hospitalization. So what that means, and what we've been talking about over the many trainings that we've had, is when a person is leaving the Oregon State Hospital, they're going to go into their home CCO rule, or their home CCO. And the rule is defining what that means, because as Michael mentioned earlier, and we'll get into more detail later in the slides, it may be that that member isn't able to transition to a facility that's in the county where they live prior to going hospital. That doesn't mean that their CCO should be changed, because that placement is temporary, and the intent is, for temporary placement, we want to get them home, and that CCO, where they'll eventually be living, needs to be aware of where the patient is, be aware of the treatment that's going on, and when that member is ready to transition back to that community, be ready to receive them and have everything in place for them to be successful. The temporary placement on our next slide, that's defined in that same Rule 1C. It means a hospital, institution, or residential placement only, including those placements occurring inside or outside the service area with the expectation to return to the home CCO service area. Again, the whole goal here is that they're not there forever. They're not moving to that facility to live the rest of their lives. It's really just for the course of treatment that they need to be in, and will then transition back home. The next slide talks about the discharge process, and so this is a little bit more detail about how that works. So let's use a fictitious member who happens to be Chris Norman. He's been in the Oregon State Hospital. He's now ready to transition, but the benefit coordination unit, when I go into the Oregon State Hospital, is coordinating with my home CCO initially when I go in. Now, that's on the slide there, it says at discharge, but the goal is to get that actually when they first go in. The process that's listed on the slide there is, this is how the CCO is going to know when Chris Norman is transitioning, is they're going to look at who is my CCO based upon the permanent residency. If I don't have permanent residency, it's going to be where the placement is. So if I've never been on the Oregon Health Plan before, I've never got any enrollment history, there really isn't any place to say that Chris Norman lives in Portland or Eugene or someplace else. But if the enrollment history indicates that I was with a CCO in a specific area, and I don't want to get too much into the detail about how the rule works, but there is some logic behind how that CCO is determined. So the next slide is then talking about some of that transition to coordinating care, and I'll let Michael speak to that.
Right. So, the residential population that we're talking about here is about 1,600 individual clients that have been through the Oregon State Hospital, and upon discharge, they're either a civil commitment or under the PSRB. Often in both of these situations, clients are not allowed or really able to make independent decisions yet. They're still stabilizing, and so, but we're wanting their input and their help as we're trying to make those transitions and placements. On the next slide, residential treatment is really temporary. It's based on the Olmstead and U.S. Department of Justice decision. It's temporary more toward independent living. And it really urges the highest level of independence and integration possible. Residential, unlike independent living, is highly structured, and that structure takes away from people's civil liberties. We need to be very careful about that. Temporary is defined in relation to the individual's person-centered service plan. This is supported through the court-ordered civil commitment process or through the PSRB. Let's turn now to the CCO responsibilities and care coordination. The member experience is that the member comes into the Oregon State Hospital. They're followed by their AIM High, ENCC. They have a social worker at the hospital, as well as they're followed by their county or the CMHP. They go through the process of stabilization, and when they're beginning to stabilize, then they're put on the ready to transition list. Discharge planning occurs especially then, but actually begins way back at the beginning of admission. CCOs are following the process, and they're ready to then begin helping to coordinate the transition and discharge back to the community. Facility placement or community placement, really the aim here is to have the client have OHP and for the CCO to be ready to accept them on the day of discharge. So there's a seamless transition into the community. The state hospital admission process is really upon admission, the benefits coordinator determines the home CCO, often based on history, but based on the rule that Chris defined before. It really loops in the Oregon State Hospital social worker, the AIM High ENCC, the CMHP, as well as the CCO, to be sure everyone's on the same page, to be sure that we're collaborating on the information that we've collected before the patient entered the hospital, and we're using that information for placement in the community. BCO then notifies the OHP account representative of the anticipated CCO enrollment, so there's no surprises. Moving toward transition, there's coordinated or integrated care with the home CCO toward independent living, no matter where the client is placed in the state. State programs have a lot of specialties and individual ways of being able to help support clients, and we need to be able to have that versatility, but it also means that the CCO needs to follow them no matter where they go. Critical partnerships, I've already listed a few times, would be the hospital, the AIM High ENCCs, the CMHP or the county mental health program, and the CCO.
All right. So the next piece, and this is really where the CCO plays a critical role. So 30 to 60 days prior to that member being discharged, that's where the Oregon State Hospital staff are requesting the OHP eligibility to start. And the home, at that point, that's when the home CCO is going to be notified, and you will get that through your account rep. So the process that we have right now is that Oregon State Hospital staff are saying, we have a member, we've identified that their home CCO is X CCO, they're reaching out, they've got a list of the account reps and saying, this member is ready to go, please contact your CCO, and then that CCO is engaged in the discharge planning process, ideally 30 to 60 days before that member is discharged. At that point, the Benefit Coordinations Unit, or the BCU, at the Oregon State Hospital consults and coordinates with the home CCO and then communicates the CCO placement information to the Oregon State Hospital and the Oregon Health Plan. Now, there's a whole lot of things that impact that. Certainly the client-specific treatment plan or circumstances will often dictate on what the facility that they're transferred to looks like. The guardianship may impact or change the home CCO. That is not happening a lot, but we have a few cases where that's happening. On the next slide, we continue with the discharge planning. OHP activates the CCO transition coordinator, and that's really, for all intents and purposes, I think for most CCOs, that's the intensive case manager. Each CCO may have a different staff person that works with that. At the Oregon State Hospital side, there's a social worker that then works with that intensive case manager to set up things like they need a primary care physician. If there's a specialist appointment that's part of their treatment plan, they get that arranged. Any related transportation, any related medical equipment, supplies, and medications. And again, I think that's probably one of the most critical ones is, and part of why this transition piece is so important is when that member is transitioning from the very structured environment of Oregon State Hospital to the facility, making sure that they've got their medications ready to go, that they've got other pieces in line and not having to wait weeks or longer to get those set up will make the difference between a positive transition and one that's not as positive. So, Michael?
Then on the day of discharge, BCU confirms with the OHP account representative the client is discharging, and the CCO enrollment is effective on the date of discharge.
All right, so one of the things that you're seeing here is there's a common theme of letting the CCO know. And again, we're identifying when that member goes in. Ideally, if in some cases we're not there yet, but the goal is that when your member is going into the Oregon State Hospital, that you know that they've gone in the hospital. And then 30 to 60 days before they're leaving the hospital, you know as a CCO that they're leaving. And then the day that they're leaving, you'll get that information as well. So part of this is trying to communicate so that you have a clear runway to know when that person's going to be transitioning and when they're going to be back either into your community or another part of the state. And that's where, from CCO's standpoint, there's responsibilities around that behavioral health coordinator, making sure that you're working with the Oregon State Hospital social worker, you're working with the AIM High coordinator, you're working with the mental health plan, you're working with the Oregon State benefit coordinator, being involved in that process to make sure as that discharge planning is happening that the CCO is involved, that they're at the table making sure they understand what the members' needs are, when they're going to need them. Essentially coordinating the care, which is what CCOs are all about, making sure that even for the clients living temporarily out of area, that those are set up. So I think, again, that's easy to talk about, but on the next slide, that does have some challenges with it. And so one of the things that we're going to go through here is both identifying what some of those are and then some scenarios that we'll go through. But really, we want to spend as much time as we can hearing from CCOs what their experience have been, brainstorming some ideas around that, answering some of the questions that we have. On this slide that's in front of you, I think, one, we know that permanent addresses get changed. And this is something that you've heard of it called flipping. We know that this is happening because of the various systems that we currently track member information in. We've done a couple things that we think are trying to mitigate this. One, of course, is a lot of education to all the different pieces that touch that member to remind them that the permanent address needs to stay at the home CCO level. Mailing addresses can change, physical addresses can change, and there's a couple different ways that systems can reflect that. But in some cases, that isn't always happening. The second on there is the CCO service areas and provider networks don't include all residential facilities, and of course, not all CCO service areas have those facilities or special programs. So if you're in a county where those facilities don't exist, and you have a member that's been discharged from a hospital, most likely they're not going to be coming to your area. And then the last thing on there is that more coordination is definitely needed between CCOs and out-of-area providers. And I think this is one of the areas that has been one of the challenges. And not that we don't know that this is happening, and I think one of the things we're hoping to hear from is for those CCOs that have had successes, what that has looked like. I think obtaining contracts with providers out of area is clearly one that is a barrier. I think that in some cases, the CCOs really just don't know that their members are in residential care. And so one of the things that we're trying to do to make sure that we're communicating this clearly is letting you know at all courses along the way where that member is and when they're going to transition. And I think getting CCOs involved prior to that the person discharging from the hospital is key to doing that. But again, let's look at some scenarios and talk about what that might look like. So part of, again, this and I think future conversations is all around partnering on how we get to tackle some of these challenges. And so we'll go through a few scenarios here. The first one is around a hypothetical scenario with someone that's discharging in February. So at February 11th in 2016, we think that's when this client's going to discharge. 30 to 60 days prior to that date, the benefit coordination unit at the Oregon State Hospital and the home CCO are now working together on the discharge planning. And so that could be a whole host of things depending on what that particular member's needs are. February 15th, now the client has been discharged, they've been out of the hospital since February 11th, they now need transportation to and from medical appointments. The tricky part here is that the transportation brokerage won't be able to verify that before the member is discharged on February 11th, because that's when the CCO enrollment is going to happen. In some cases, some transportation brokerages are saying, well, you know what, we don't see the member eligible, therefore we're not going to book the ride. We had one CCO that worked with that transportation brokerage, explained what the member's transition was, explained why it was critical that the transportation be set up for that appointment, and on February 15th, the member got that ride. I think that's the case where it was really worked about as well as it could. But I think there are some other scenarios that we want to have some people thinking about what are some other ways that we might address that. So Michael's going to talk about the next.
Just a quick thought before we move on. You know, this can happen too with appointments with primary care and specialty care and durable medical equipment. You know, they're not showing up on the system as being on OHP, and yet we as the system know that they will. being able to communicate how to best coordinate those processes are really quite critical. And this becomes even trickier when we go for an out-of-area placement. Let's say we have a client whose permanent home is in the Willamette Valley, let's say Salem. The client is placed in a residential treatment in Eastern Oregon. How can the home CCO coordinate out-of-area care? So this can happen in both directions too, from the Willamette Valley to Central and Eastern Oregon, or reverse. How do you do that quickly, fluidly? Some CCOs have really established a fluid process where they have fairly brief contracts that are very client-centered and client-specific. And if there's a pattern of working with clients in that specific area, then further contracts are pursued in more detail. But the client-specific contracts are really fairly general and pragmatic to the issues at hand. You know, how do you cope with that? What kind of time frame do you need for that to occur? And we can get into that in the next scenario, because time frames can suddenly change. Short notices are not unusual. A client's, you know, let's say the client's permanent home is on the coast. Placement in residential treatment is planned for Portland, and discharge planning is right on track until 3 days before that time when the placement needs to be changed to Salem. Now, there can be all sorts of things that create that. The bed that was opening up in Portland may have needed to be postponed because something happened for that client, therefore not opening up the bed. It could be that something happens for the client in the hospital waiting, and they're needing a different specialty of care to be able to make transition into the community more successful. So as a CCO, how would you cope with that? Could you make that kind of move, that kind of shift fluidly? Given only a few days, could you be able to pull that off? Some CCOs are, you know, again, are better at this than others. Sometimes it's out of practice, sometimes out of skills. So we'd really like to be able to hear from you about what your successes are, share those, as well as what your challenges are, and see if people have solutions to those.
So again, I think onto the last slide here with recognizing that we have 16 different CCOs and 16 different ways of doing this. And I think that we realize that particularly for those scenarios where the member, particularly the last one, I think is probably the most challenging, where you have a CCO, they know that their member is going to be transitioned, they know it's going to be in an area that it is their current service area, and then because of an open bed, because of a treatment need, that member then goes to get a different community, and maybe that facility or the CCO had already arranged for some services in the area where they thought they were going. Now that's changed yet again. And I think that, again, we know that happens. We know that the time frames get short. We know that CCOs have to be nimble, and sometimes these situations are pretty fluid. But that's where we want to hear what's working for CCOs. We know that some of the things aren't working. We can identify clearly that those are some clear challenges, because a lot of times CCOs are very comfortable with the provider networks in their own communities, but how do you then work with those when they're across the state? Now, the good news is we have 16 CCOs that are throughout our state, and so I don't know if CCOs right now are working with another CCO maybe that's in the area where their member is located to understand what is the provider network look like on the ground. Who do you recommend? If we're looking for a primary care physician, if we're looking for a dental provider in a part of the state where you're not familiar, what are some of the ways that CCOs are strategizing to find out that information and work with those providers to get the care for those members? So this is the part where we really want to open it up for some Q&A to hear, and I think Jennifer will help facilitate some of the questions, and we'll let her talk about that, how we do that. But we certainly don't have the answers. I think we're a few months into this process. we've heard some success stories, we've heard some of the challenges kind of anecdotally, but we wanted to have this both to raise what the process needs to look like or should be looking like, but also to hear from CCOs on what you're experiencing, what's working well for you, where are some challenges, where are some things where we can help on the provider side, where are some things that we can help on the process side. With that, Jennifer?
All right. So we do have a few comments and questions that have already come in. First comment is, we have seen folks come out of Oregon State Hospital with no benefits arranged prior to discharge, which leaves the resident without any OHP coverage at first and providers no service payments for months. So that's a comment, and if either of you want to speak to that.
Well, I mean, I think this is Michael. You know, there have been snags in the process. The goal certainly is that patients leave and on the day of discharge are covered. The CCO is expecting it. Behavioral health providers are expecting it, and everyone's ready to go. Clearly, that doesn't happen all the time. You know, historically, these kind of glitches have happened more often, but we are really trying to address that through the system. Hopefully, that's an example from several months ago and not current. If it is, I mean, certainly those can be problem solved through myself or Chris, and we'll be able to refine the process.
And this is Chris. I think, like Michael, we have heard of some scenarios like that. I think we can all agree that that's not an ideal solution. The things that we're putting in place, we're trying really hard to make sure that that doesn't happen. But again, if you're finding a scenario like that, let's work together and figure out how we can address it.
Okay, so the next question is several questions together, and I'm going to read them all, and then maybe we can go back and address each one because they may be tied to each other. I'm sure they are. When you say that a guardian can change the CCO, how do you see this is possible? Shouldn't the permanent address remain the same? Also, isn't the AIM High worker participating in the placement into the hospital? It doesn't make sense that the CCO doesn't know they are at the hospital. And then who signed off on the long-term care application?
So I will.
Sure. Is it long-term? LTC wouldn't be anything other than long-term care, would it?
Long-term care, right.
Okay, just want to make sure.
I'm almost wondering if we take those in reverse. If we want to start with the long-term care, which I can actually address, I'm not sure, Michael, if you can, into the AIM High, and then talk a little bit about the piece around how members use. But should we take them in reverse order? Would that work?
Sure.
Okay.
Sure. Yeah. So, you know, in the long-term care application, let me blend some of these. The ENCC should be definitely a part of that process. The sign-off happens with everyone on the team. The patient signs off on that, the ENCC and the social worker, the representative from the hospital. You know, the community should be involved with that, all of that. So, I mean, that's really the culmination of all of this coordination. So, it shouldn't be a surprise to anybody. Now, the AIM High ENCC has been a part of both the admission, the treatment strategies, and coordination during the hospitalization, as well as coordinating the discharge and the placement of the patient in a variety of different programs, and they cultivate those options. So the ENCC should be involved from before day one through to out into the community and outpatient care.
So I think there was a part of that question at the earlier stage around when a member or a member's guardian can make a change in CCO. So I think for most of those working familiar with enrollment changes, members do have the ability to make changes in their enrollment. There are circumstances where they aren't necessarily able to make those decisions. I'm thinking like a forensic stay, but in other cases, the member really does get to choose, and I think that's where we do have situations where members are discharged to a specific area, and it may be because they have family in that area, it may be because that's where they want to live. And to some degree, the members that are at a stage where they can make that decision, just like any other OHP member, they get to choose. They get to say, you know what, I now live in this community of Salem, Oregon. And so we have to be cognizant of that, but we also know that if they're at a facility that is truly temporary and for all intents and purposes, they want to move back to Burns, or they want to move back to Bend, that's going to be the CCO, and certainly if that's where their enrollment history is, if that's where their permanent residency is, that's going to be where their CCO is. But just like members do all day, every day, members can come and say, you know what, I moved, I now live in this county, and that county may have one or two CCOs, and I'm going to choose this one. And a lot of times it isn't that they're choosing a CCO, they're really saying, you know what, I now live in Hermiston. Okay, Hermiston has a CCO that serves that county, and that's not going to be their place for that. I think one of the things that we've worked really hard on is to track all of the members that are in all that, as we mentioned before, roughly 1,600 members that are in residential facilities throughout the state. We track those on a monthly basis, and our goal is to make sure that we know what's happening with those folks, so that if someone does choose a plan, we know that they've chosen it as opposed to the system flipping or something unintended happening. We're not there yet. We're working on it, but we're a lot further than we were. And the goal is that we be able to start pulling some reports and let CCOs know where those members are throughout the state. Again, that's our goal for 2016. We're a little bit away from that. But again, it is sometimes difficult to be able to know when that member has chosen a plan versus when the system's done something it's not supposed to. Were there other parts of that question that we didn't cover yet, Jennifer?
I may have checked out for a moment because I was typing something in. So let me make sure that we checked, that we covered signing off on the long-term care application, the CCO not knowing that the person is at the hospital, the AIM High worker participating in placement, the permanent address remaining the same, and the guardian changing the CCO.
Yeah.
Okay.
Just to cap that off, we haven't made this distinction yet today. We're talking mainly about non-PSRB clients. PSRB functions as a slower process. They're placed for longer, and so there's some differences in that population. So we're mainly talking about the civil commitment process and those clients referred to.
Okay, next comment. This will require consistent and reliable communication from Oregon State Hospital with CCOs. This has not been our experience thus far. We do not always learn about OSH discharges until after the discharge.
This is from a CCO?
Sure.
Yeah.
I think so. And again, I'm not sure if this is the CCO's experience from last week or last year. I would agree that we are not at 100% of where we want to be, but the goal is to get that communication in those 3 different times I mentioned. So at the time of entry, 30 to 60 days out from discharge, on discharge day, or very close to it itself. So that's our goal. We're working towards it. We're putting some processes, or actually have processes in place to get there. If CCOs are continuing to see that that's not happening, please let Michael or myself know, and we're happy to follow up and see where the process didn't work.
Right. Yeah, CCOs are often involved with the payment of the acute stay that leads up to the state hospitalization. So that there should be some sort of processes in there to alert the CCO, just in payment-wise, in addition to the coordination that the ENCCs are doing through AIM High, the county mental health programs, as well as then the caseworkers that are working with that patient through the CCO. I've also, if I can add to that, I also work very closely with the hospital, who are really striving. They know that communication has not necessarily been very fluid and open. They are really striving to be sure that they are improving that, and they are really wanting that to happen. So I encourage direct feedback too to the hospitals, to the caseworkers, and help polish this system so it really ends up being the way that we all want it to be.
Okay, next question. Not all of those who are discharged, it skipped on me, will be eligible for CCO coverage. For instance, Medicare only, what happens then?
Those folks would go to fee-for-service, and I assume Medicare only as in dually eligible, otherwise they wouldn't be OHP members at all in the Carver conversation. You're correct. If they're dually eligible, those members can choose to be in a CCO or not. The default is that they would be fee-for-service until they tell us that they want to join the CCO.
Next question, how does the CCO cope with counties that report that all primary care provider offices are closed to new clients?
That's a great question. I think that's one of the things that we were thinking. It'd be good to hear from some CCOs on what they do there. Again, we can speculate on some ways that CCOs might want to reach out to the CCO maybe that's in that area and see if there's relationships that they can recommend. I think there definitely are communities that have limited access for primary care. So I don't have a pat answer to that, other than that's one of the things that we're hoping that we can brainstorm a little bit around today to see if there are some CCOs that may have some successes with that. So if you're a CCO that has encountered that and had a good solution, you want to type in maybe something there, or reach out to Michael and myself after this. We're happy to do some follow-ups to this presentation today.
Okay, next question, what if a temporary residential placement becomes 1 to 2 years or longer? At what point does it make more sense to transition to a CCO that is in the actual area of residential placement?
Also a great question. I think one of the things that we're looking at is when that member has been there, and part of this too is we are really looking at as a temporary placement. One of the things that we are encouraged by having the CCO involvement is that that's where the CCO is going to know, you know what, is it that this member is not getting better after a year or longer of treatment? And if so, why? And if there's a good reason for that, then maybe the member needs to stay in treatment. But I think one of the cases, or one of the things that we think will happen through this is that there may be members that don't return home or that stay in treatment longer than they should be because there isn't anybody that's actively looking to make sure that that member transitions back. Having said that, I think there's also times where that member is going to reach a point where they both have the ability to choose, and at that time, that's where we're looking at a process that we don't have in place yet, but we're working to have this year, where we have some process to go out and ask those members, one, if they're at a place where they've been in a temporary placement for a while, but are at a point where they can make a decision about where their permanent address is, to do that. And that would then say if the member's been in that community for a year or two and feels like that's home, then they can make that decision, like our members do that move throughout the state right now, to formally say, you know what, I'm now going to make this residence permanent. I have the ability to make that decision, and I'm going to make it in a process for then facilitating that change that will then make the permanent residence in whatever the community that they're staying in. I think that the other part of that is, do we have a specific time frame when there's a date that says, okay, you've been there 2 years and now that's now your home? We don't have that, and I think to some degree we can't. We would continue to think that this is a temporary placement because of Homestead and all the other regulations around this, but I think that's an ongoing discussion. It's a great question.
It really has to be flexible, and it's really so client-centered, we can't put a number on it. What I certainly want to avoid is treatment programs requiring a move to the local CCO. That is not appropriate. The home CCO that follows the client, that has all the information, both medical and psychiatric, needs to be following and coordinating care no matter where that patient is in the state. The treatment program does not have the platform to require the client to be transitioned to that local CCO. That's inappropriate.
Next question, can you please explain why an individual is closed to the home CCO and how other CCOs coordinate and set up care when they aren't open to them? I'm not sure I understand the question. Yeah.
if we could ask the person who submitted that question to maybe clarify, I'm not quite sure what they mean by closed, if it's closed in the sense that there's no providers available to them, or if it's closed, that the CCO itself is closed because it's in an enrollment limit, or they've chosen not to accept new members. I'm not sure.
I wonder if this means in MMIS. So they are they're not visible to them in the MMIS.
Okay.
Or provider web portal.
Because they're still in the hospital name.
Yeah, if the person who submitted that question could just clarify, because I don't want to give the answer assuming that's what they mean. So,
okay.
I think if the question is, if MMIS doesn't display that CCO, what is the process? And that's what the person is, okay. Mm-hmm. So to some degree, I think that we haven't encountered that yet. It is certainly possible that when the member is admitted to Oregon State Hospital and the benefit coordination unit is looking at that and seeing that this member is in a CCO that appears to be closed, one, obviously when they go into the Oregon State Hospital, that's not the time where we're concerned about it, but if they're discharging from the hospital and the CCO is closed at that point, we would still act as if they were living in that community, and just like anybody else who's in a given county, they would then move to fee-for-service. And with again, the assumption that their home CCO is closed, if they open, that permanent residence is still going to look at that member, regardless if they're temporarily out of the area, and then assign them back to that CCO when they're there. Now, that's going to create some coordination challenges. I think right now, I can't think of any counties that are currently closed, but that is how we treat that particular scenario.
Okay. Is there a reason the enrollment cannot be sent to the CCO as soon as the state is aware that the member will be enrolling after discharge? Without the member in the system, it is difficult to track care. So did you just address that?
No. So I think that's a separate issue. I think and it's a great question. What that person's asking is there a way to get a future effective date for the enrollment? I think the short answer right now is no. That doesn't mean it can't be pursued, because I would agree that is one of the challenges, and probably one of the biggest challenges that we identify right now is we're talking about a member that is going to be yours, but there's no record that you have that the member is yours. And I think that's where we fully anticipate that that's going to be a real coordination challenge, that we're talking about a member that you don't have in your system yet. And today we don't have a process for doing that. I think that's one of the things that we're looking at. If you have other feedback on that, please send it to me. My information will be at the end of the slide deck here. I'd be happy to look at what some potential solutions might be, but today that doesn't exist.
We had a similar experience where a member was in mental health residential treatment last month, and we were told enrollment would not be changed, but we were not the home CCO. What steps will OHA take to ensure enrollment in the home CCO is actually the correct CCO?
So I think I'll reflect that question back and interpret it in the way I think I heard it, which is we're a CCO. We have a member that is in a treatment facility in our county, but is in a different home CCO. And I think what they're asking is, how do we make sure that that person stays with the CCO that they came from and doesn't get moved to our CCO? So again, I alluded a little bit to some processes that we have right now that we're tracking all members in mental health residential to make sure that those changes don't happen. And we know that they're still happening on kind of a spotty basis. We're trying to track those down and figure out if it's individual staff that are making those changes, or if we have system issues. We think we've eliminated the programmatic and system challenges. Right now, most of what we're finding is that someone's gone in and made that change. The question, I think, kind of at the end of that was, how do you know that the member is assigned to the correct home CCO? And I'll go back to some of the slides we had before. There is a protocol that we're looking for, which is, were they in a CCO when they were admitted to the Oregon State Hospital? That would be the CCO that we're looking at. If they weren't enrolled at that particular time, what was their enrollment history the 12 months prior to that? If they weren't enrolled 12 months prior to that, what was their permanent residence information that we can see from some of the state records? If you're finding where you've been assigned a member that doesn't appear to follow that logic, please let us know. That logic is currently done through the Oregon State Hospital unit. They have been pretty comfortable with making those assignments, but that is a human process, and certainly that interpretation is certainly open to misinterpretation. So I would say if there's a case where a CCO feels like, you know what, this member was discharged, we've been looking at it, we're not sure why this member we think is in our CCO, let us know. We'll take a look at those and research them.
And the next two questions are related, so I'm going to read both of them. We struggle to find PCP providers specialists that will make agreements with out-of-area CCOs. They are busy, have enough business, won't take more patients from own local CCOs, much less out-of-area CCOs. And then the question, lack of PCP is critical for those discharging from OSH. Is that not a requirement of OARs? They're kind of related.
So I think, again, this is one of the big issues that we know CCOs are having to work through. And I think to some degree, we don't necessarily have the answer of like, yeah, follow these 3 steps and it'll all be work out. But we are knowing that there are some CCOs that are able to work through that. And so I think if hopefully some of those CCOs are on the call today, if not, we'll be out soliciting those. But that's kind of where we think that there might be some best practices to share across CCOs, where maybe a CCO has figured out a solution to that. Because I have heard that, hey, I'm a CCO, I'm willing to provide services to our member, the providers aren't willing to work with me. Now, that's not unique to this scenario. I think that happens throughout the state for all of our members, not just those in mental health residential, but certainly that's more important for those people that are going to be in a temporary placement for more than a week or two. And we are looking to see what CCO's experiences have worked and what hasn't. We also think that part of the feedback that we were hoping to get today is if there's a common theme that we're hearing from providers, we're happy to do some education with those providers and say this is why it's important that you contract with the CCO, even though they're not in your county or in your community.
I can add a little bit to that in relation to residential treatment centers. When a facility collaborates with the medical profession, often they have favored providers they've developed over the years to that work in close collaboration with the program. Because treatment centers are a statewide resource, those medical providers need to kind of realize what they've kind of signed up for. Some programs have been more localized than others, but the fact of the matter is all of those programs are statewide resources, and they do need to cultivate primary care as well as specialty care relationships for their clients so that clients from everywhere in the state can be able to benefit from the treatment and the medical support of that treatment. So the CCO can be helpful in pursuing who those might be, but the programs, I really want to encourage the programs to really cultivate those other relationships so they can serve those clients.
So let me give you an example, Michael, that I think I heard a few months ago. One of the facilities, because of the type of care they were providing, they had a dentist that was willing to work with them because some of their members needed special care. It wasn't just someone they could send in a van to go get a routine cleaning. This was people that had a whole host of anxiety, and this particular dentist was willing to work with that facility and meet some of their special needs. I think what I heard you say is if you understand what that facility is using and if they've got a specific dental provider, that's what the CCO can then say, tell us who that provider is, we'll reach out to them.
That's right.
And that facility can then say to that dental provider, we've got this member, you need to work with a CCO because that's just going to be able to pay the bill for you.
Exactly.
Okay.
Okay, and I'm going to read a comment that just came in. Seems that if each CCO identified a contact person that could assist other CCO staff in facilitating primary care in their region, at least each CCO would have a person to contact when they're in need of assistance.
I think that's a great idea.
That's a great comment. Thank you. All right. Back to some questions. It would be helpful if the Q&A are sent out to the group participating in the call. So we do have one more slide, actually. I'm going to go ahead and advance to that slide really quick. And it has the, excuse me, the website and also an email address that you can contact us at. So on that website, we do have a frequently asked questions, and it is likely that that could change with a lot of the questions that are coming in today. So do keep an eye on that website because we do go over the questions frequently and add and change those. All right, next question. Are discharges to adult foster homes out of area being handled in the same way as residential placement?
Yes. Fairly easy. Yeah, it really works the same kind of way. Foster homes, you know, it's really interesting. Foster homes in the system are geared to address lower needs individuals. But you know, functionally, that's actually not the case. I mean, there are some foster homes that address some very high needs individuals and do a great job of doing that. So really, I mean, the answer is yes, the function is the same way.
Home CCO remains the same for mental health, but who makes the temporary change on the physical health side?
So I don't, if I understand the question correctly, the home CCO on the mental health side and the physical health side are the same.
Right.
I think I'm trying to think of a scenario where we discharge someone that would have a CCO E or G, and the physical health might be fee for service. That would not be the intent unless there was a case of, well, with the exception of duly eligible Medicare, Medicaid members, Heritage Native American, those folks would opt out of managed care. But I think that again, the statewide population is only 1,600 folks. The percentage of those would be very, very few. So I think that for all intents and purposes, the member would be in a CCOA and have mental, physical, and dental health all through the same CCO.
Okay, isn't the individual allowed the right to choose CCO based on where the individual wants to live? At what point does the individual have a right to decide?
I can answer that a little bit just based on Olmstead kind of processes. The client always has a right to have input into the placement, even if they're on civil commitment and the such. They don't have the sole ability to do that if they're on civil commitment because they really don't have the history to demonstrate that they can really care for themselves, hence the reason why they're on civil commitment. We still ask for their input, though, and try to address those desires as much as possible. After civil commitment, the client has a lot more say into where they want to live and how that aligns with their plan and all of that. My emphasis would be that decision should be based on their person-centered planning, and not on any pressure from the treatment program, or from the outpatient services, or from the medical provider, or the local CCO. So they should have that choice to be able to pursue their own goals. If they have a guardian, they should have input on what the guardian decides. But again, they have a guardian because of a history of having difficult time making decisions that are in their best interest. So they have input, but they don't yet have total say over that.
Okay, so a couple of combined questions here. We had a comment that said, please give specific examples of those who discharged without benefits so we can investigate where the issue is. And that's coming from someone on the OHA side. And then you indicated that we can contact OHA if there's a question about eligibility. And would both of those things go through the email address that's on the screen now?
I think the short answer is yes. We do have a process that goes for our client enrollment services, but I think it would be helpful from a CCO perspective to know specifically what that is. We do have some processes if we need to make the enrollment changes, but I want to make sure I understand what that question is too. So.
Okay. Just a minute left. I'm going to go ahead and take the one more. trying to get one that's not too
You can answer in 60
complicated,
seconds.
right? There are also issues with coordinating care and DHS-required assessments for DHS foster children who have been placed out of a CCO service area. Who can I contact to discuss the issues for this population? Do we know in the room?
I could help with that. I don't know right off the top of my head, but I can figure it out.
Okay.
I'd probably connect you with someone over at the KISS team that would be able to directly say, but right now, because I think management is under transition over there, I've got to ask around to see.
Okay, so with that, we're going to go ahead and close. Please do contact us if you have any questions or suggestions, and remember to stay informed at the website on your screen now. Thanks so much for being here.